right. Hmm. Okay, welcome. My name is Callie. I work with Promises. This is our second year of PBHU webinars. We're giving 2 free CEs every single month with different experts leading different conversations every single month. Fourth Friday, we're here every month. So today we have Bill Anderson, and he is speaking to healthy humility in therapy, avoiding the pitfalls of overconfidence. Bill, you can go to the next slide. I will introduce you. More about Bill. I'm excited to introduce Bill. He's a seasoned senior executive, newer to Promises, but with over 30 years of experience and a deep passion for the mental health field. Throughout his career, Bill has consistently built strong, mission-driven leadership teams, whether in large organizations or more intimate settings. He's known for his ability to create a clear vision, rally people around it, and move with that vision forward while preserving the heart and culture of the organization. Bill brings with him a wealth of expertise in the recruiting and retaining key leaders, driving revenue growth, managing expenses, and most importantly, enhancing the client care, client safety, and engagement. We're very fortunate to have him here today. He's joining us from Atlanta. He's our executive director at Promises Atlanta. You can go to the next slide. Welcome, Bill. So who we are, Promises Behavioral Health is a network of treatment centers across the country. We have residential mental health care, residential behavioral health, addiction care, as well as IOP, PHP, and step-down opportunities. We really focus on those clinical outcomes. So we truly use the treatment programming. We have 30 days of unique programming. When you come to a Promises location, you're not repeating every day, doing the same things. Every day is different. Every facility has its own unique personality and programming benefits. So if you're interested in learning anything more about these individual programs, please reach out to me. Or you can go to promises.com. We are in Texas, Tennessee, Pennsylvania, Massachusetts, Georgia, and Florida. You can go to the next slide, Bill. Okay, so during the webinar, just 2 things. The chat box, which you're all already using, those are going to be questions for me. So if you have any questions regarding the Wi-Fi, the CEs today, drop those chat questions there. Questions for Bill regarding the actual webinar content, put those in the Q&A box. So I want those to be separate so that way whenever we have the time for questions, Bill doesn't have to sift through your questions about your Wi-Fi. We can keep his questions separate from mine. Chat boxes for me, Q&A, questions for the content is for Bill. Okay, next slide. The CE process. So you are required to stay for the full CE training to receive those 2 full credits. So you can't stay for 1 hour and receive 1 credit. You have to stay for the full 2 hours. Now that you are all already here, that's a great start. So just stay with us until the end. And just a reminder that you have to be using your own individual device. So if you are with your coworker and you're sharing your computer, only one of you is going to get the CE credits. But if you also just want to join and participate today, you're welcome to just, join with that other person. Only one of you is going to get the credit though. And then just know that if you need to hop to your phone or back to your laptop, that is totally fine. The webinar will follow you. So that is a-okay. After the training, you're going to be going back to your CEGO dashboard, the same link that you used to join today through the email. And from there, you'll see reminders for the eval. So make sure you complete that eval within the next week. That way you can receive your survey or your certificate, and the certificate will just be completed and uploaded directly into your attendee dashboard. And again, those are issued from NADAC and NBCC. Oh, slides, other resources, anything that Bill mentions that you're like, I want more of that. I will also be putting all of that into the attendee dashboard next week. I will get that question several more times. That's okay. You will get the slides and other resources that will go out next week. Okay, thanks. Bill, I think I get to pass this over to you now. I wanted to let Bill introduce Promises Atlanta a little bit more today before we get started. If you all need me, I'm in the chat. Thanks, Bill.
Thank you. Thanks, Kelly. One, appreciate the introduction. Very kind and generous, and I appreciate that. So yeah, let me talk a little bit about Promises Atlanta, and then I'll do some other thank yous and housekeeping stuff before I get started. Promises Atlanta opened up probably about 4 or 5 months ago. We had our first client April 2nd. We've been working on this project for a while. I think Promises had the property about a year ago almost, and we opened the doors around September, October to start renovations inside. Gorgeous facility. It's a 37,000 square foot. Like I said, renovated program, 80 beds. We have a mental health wing, we have a detox wing, and then we have a residential substance use disorder for women wing, and then we have a residential substance use disorder for men. So all of the wings, including the mental health, have kind of a weight room. We do both double rooms and individual rooms. But like I said, it's a beautiful facility, event space. We have a fairly large gourmet kitchen where we have our cook chef do the meal preps there and take them to the units. So we're having our open house. I'm going to put a shameless plug in there. We are having an open house. So if you're in the Atlanta area or in the Georgia area, we'd love to have you. And that's on July 25th. So that's from 9 to 12. So we'd love to see you there. If you haven't RSVP'd, you can go onto our website and look for the links on there and RSVP so we can at least have a count. So that's a little bit about Promises Atlanta. A little bit about this or this presentation. There's a couple things. One is, thank you to Callie for helping with all her help getting this stuff together. She was tremendous. Trish Caldwell, who's our VP of clinical services, did an incredible job helping me out throughout this thing. Special shout out to Shoshana Raposa and of course Tiffany Brown. They both helped me. And if you like it and it's really good, it's because of their input. If I fall flat on my face, it's all on me. So those are the caveats I have. And I have not done this for a while. So this is, I'm a little rusty. Someone said that it's like riding a bike. Well, that may be true, but I've never ridden a bike in front of 300 people. So we've got that. So that'll be a little bit different. So, bear with me on the rust part. I'm used to doing live presentations where I can kind of feel the energy. And then I thrive on questions, those kind of things. We will have a question about halfway through. My goal is to go about 45 minutes. There's a good break in here, and then have a 7-minute break and then come finish up with the last couple pieces. So that's my goal, is to get us out of here and get some time for some questions. And then the last piece before I dive right into kind of the history of psychotherapy is I really enjoyed Michael's presentation, The Brain Gut. I listened to Trish's presentation. Both of them were very educational and informative. This is going to be more philosophical in nature, I think. I think there's be some reminder, like the history of psychotherapy, our current landscape, those kind of things. But I think it's going to be a little bit more philosophical in nature than expertise. And if you're here to learn some kind of new modality, that's not me. I will talk about different modalities. I'm going to highlight 3 different modalities that we use in the industry. I'm going to talk a little bit about them. I'm going to talk a little bit about the impact that they have. But I won't be training you on a new one. I'm not going to be teaching you something that you can add to your repertoire. So I just kind of want to put that caveat out there so that we're on the same page. I think that's most of my housekeeping stuff. We'll follow the objectives pretty straightforward. Yeah. So the history of psychotherapy. Why do I think the history is important? It sets the table for our current landscape. So there's a point in this talk where I talk about our current landscape, and I think knowing a little bit about the history. I'm not going to do the full history, but I want to start kind of right in the 19th century and talk a little bit about that. I also want to talk about what's happening right when Mesmer and Charcot, and then right before Freud and Bauer. At this same time, it was around kind of Victorian, into the Victorian ages, and we had this idea of the bourgeois family model. And the reason I think that's important for us is that's kind of the beginning of the nuclear family. So when we talk about the current landscape and the changes in our landscape, we always have to consider family, right? And so this was the kind of the beginning of the family structure. It was kind of they were identifying their roles in here. So you started to have the concept of the homemaker, and then the primary earner out there, whether it was in the field and the farm or whether it was cultivating those things. So you had that kind of nuclear family. It started kind of at that upper middle class, but it trickled down to the kind of peasants, the lower class, and it trickled down. And so that was kind of the emergence of that nuclear family. So I think that's important as we talk about um, um, the birth of psychotherapy. Mesmer did a really good job of introducing hypnosis. And the way he would do that is um, he would touch individuals and touch them legs somewhere and try to hypnotize them. He also used, interesting enough, and we'll talk this in a different slide, is he used magnets. So he believed that the magnets had an energy and had the ability to draw out, not really psychosis, but draw out feelings, bad feelings, those kind of things. So I think the beginning stages of that, Charcot kind of legitimized some of his work. And then we jump right into Freud and Bowers, who kind of normalized what they called that talking cure, right? Um, and they kind of, Freud set the bar for kind of psychotherapy for the next probably 50 years. And he had a lot of people come right behind him, right? So they were doing studies on hysteria. They got what Carl Jung, they got Adler, they got Klein, Otto Rank. They all came right behind Freud. So Freud set the standard for the next 50 years. Um, and so I think that's important for us to be aware of. And we still talk about Freud, right? We still discuss Freud's impact, whether it's the ego. We always talk about the ego, superego, those kind of things, dream interpretation. So it's something we still use today. Like I said, those are the early developments. So Freud had impact on all these individuals. I do think it's worthwhile to talk about Skinner. Skinner off of Pavlov. We remember Pavlov and his um, studies on responses, right? And Skinner was operant conditioning, so conditioning behavior responses. So Skinner was working on that in pre-50s. And then I do think it's important for us to discuss, Carl Rogers, Maslow's hierarchy of needs. Everybody, if you're a licensed person, is one of the things we studied. Um, I'm assuming they're still teaching that in school as far as Maslow's hierarchy needs, probably definitely in the history classes of psychotherapy. But the idea for person-centered therapy with Carl Rogers, that's very important. Carl Rogers was very firm in looking at actualizing, right, the self concept, and he looked at incongruencies between those two things. Where you wanted to be and where you actually were. And he wanted to measure and look at those incongruencies, right, between those two ideals. And he really focused on kind of three things: being genuine, unconditional positive regard, and empathy. And when I get to kind of the conclusion of our talk, I think those three things will resurface. But Carl Rogers was known for that person-centered therapy, genuine positive regard, and empathy. So I think those are big and important things as we talk about this. And then of course you can't move forward without talking about Beck and CBT and Ellis. I think that's kind of the roots as far as we moved into not just treatment, the treatment industry, but how we view behavior, how we look to change behavior. CBT had a huge impact, not just on our current landscape industry, but even as attitudes towards mental health and SUD grew. That was a big impact. And then, of course, our family systems. Family systems, very important as we look. And again, we talked about kind of the birth of the nuclear family and where that was going. So looking at those therapies, the impact of systems, attachment, right? Attachment disorders, those kind of things, very important, and where we end up. And like I said, CBT, how important that was, that's the basis for DBT. I'm going to talk about those two later on a little bit more in depth. But that was a huge one. Nowadays, we talk about innovation and where we're at, trauma-informed therapy. I'll spend a little bit of time on trauma-informed therapy and how that is moving us forward in this industry. It is widely talked about. Um, we discuss it in treatment, we discuss it in therapy, we discuss it in the mental health world, um, trauma informed or working on trauma. Um, for me, it was is we knew that trauma existed, but probably in the I don't know the mid around 210 to 212 215 that became prominent. Like everybody wanted to be trauma trained, trauma informed, and that became a big movement in our industry. It hadn't always been around as far as we knew trauma was there, but we weren't as focused as we are now. And then the digital landscape, AI, I think we're going to move a lot more in this direction using AI. And it's not just chat GPT. I think as we look at apps, the impact of apps, if anybody's doing, we do here at Promises, we do Encircle. It's incredible. It's not an app based, but it is a cloud based platform where we can reach out via text and keep connected and do all those things. And the ability for AI to move past what we program it and really to kind of incredibly enough, pick up on actually clinical skills and not think like it, but respond like a counselor would. I think we're going to be amazed as we move into that digital landscape and where we go. And then, of course, telehealth, which kind of exploded around COVID time, and we still now with insurances allow that. It's accepted now. Before then, it was tough. You could do teletherapy on a limited basis via insurance, and they would accept it. But nowadays, it's accepted. It's widely used. You can do it. Almost every insurance company accepts it as a form. And then we're also looking at how the brain is changing and those kind of things. One keynote on that as far as DNA, right? DNA, they have really done a lot of work on DNA. We used to believe that was it, whatever you had, but they can really kind of look at behavior and changing kind of patterns in your DNA based on how you respond, how you react, and really looking at those. So there's been a lot of studies on DNA and the impact that it has on mental health and SUD treatment. Some side notes as far as brain stimulation goes. Um, just had a huge impact. We see there ECT, in 1938. We see TMS. For me, even though it had its, FDA approval earlier on, it didn't jump on the scene with me until about 2015, 2016, working with a program, and they started using TMS, transcranial magnetic stimulation. Again, we go back to that idea of using the magnets to draw it. As it was for depression, treatment resistant, and when it first started, they would kind of want to see, what medications have you used, what medications were you on, before they would start kind of the TMS episodes. And I can't remember. There's a number of episodes you have to do. It's not like a one time only. I mean, you have to go through a series. There's some pre-test, there's some post-test, and a series of that stuff. But it jumped on the scene. They still use it. Even on ECT, there are programs in the Atlanta area, and I know around the country that still use ECT. It's changed, of course. It's evolved from its first preliminary, much safer, much more client friendly. And then we also have recent, looks at the vagus nerve. And if you're not familiar with it, the vagus nerve runs from kind of the base of your brainstem there and goes all the way down your spine, and it hits all your nerves. So they're looking at ways of how do I impact that nerve? How do I impact the nervous system and to kind of create and treat depression? So those are kind of just want to kind of talk about those are going on at the same time with everything else. Kind of the evolution of treatment. Really, when I'm talking about SUD, I just want to kind of briefly talk about this. Current MAT was not the first time they tried opioid maintenance before. It didn't last. They just couldn't find the regulations. We know that opiate use has been around for a long, long time. I think nowadays it's used differently. Um, back in the day, it was always smoked. We moved into what the 50s, 60s, 70s, and heroin and injecting, and even through the 80s and 90s. It sticks around. Sometimes people say it went away in the 90s with crack cocaine and with meth coming in the late 90s and early 2000s, but it didn't. It's always been around. It's a staple in the SUD world. It's more used in a variety of different ways now, but they've always tried to treat it. We had Alcoholics Anonymous has come on. We had the Minnesota model, which is the 12-step model. And we really kind of hung on to that for a whole while. I just want to talk really briefly. As I came into the industry, a couple of things that stood out to me was, one, in the Southeast arena, we held on to this abstinence-based kind of mentality for a long period of time. I think in other parts of the country, were looking at MAT, they were looking at the research, but we hung on to that abstinence for a long time. I still think there are a lot of pockets that still hold on to abstinence. Don't get me wrong, I think long term, the abstinence based are your best chances of success. But what we're learning is that there's a variety of ways to getting into treatment, and that MAT saves lives, right? I mean, that's the research. But when I got into it, was abstinence based. The other thing that was kind of big in the treatment landscape was this. It was behavior modification. It was CBT, but it was really kind of a confrontational style. It was really challenging those behaviors, almost having that client look at their behaviors through someone else's lens and the impact their behavior had on loved ones or society. And if we could get them to see that enough, they would change. So it was a very confrontational. And then we moved into motivational interviewing. We kind of shifted away from that challenging piece to inviting them into the conversation with us, and just trying to see that. And then, of course, we've got DBT that came on the scene. It was in the 80s. I'll talk about this later, but it was in the 80s, but it really came onto the scenes in the treatment landscape, probably in the 2000s, where people were starting getting trained on DBT, and you had DBT classes, those kind of things. And I'm going to talk a little bit more about that in a little bit. Behavioral therapies and regulations, right? It continued through that. We see the emergence of CBT as the kind of way that we treated people, and we were focused on it. Naltrexone, buprenorphine, and started to do a lot more integrated approaches, right, to treatment. So we moved into that realm and doing a lot more of that, to where we get to kind of where we are a little bit. MAT, harm reduction, digital tools, being more focused on the individual and their response to medicines, right? So now we can do genetic testing, right, to see which medications are going to be absorbed by an individual, which medications. It's not just the side effects, that testing is really to see what is going to be better suited for the body, and what they can handle, not handle, as far as digesting and impacts, their chemical makeup. I think Michael talked a little bit about that as far as the brain gut and those kind of things. So that's where we've ventured into, right? And then mental health treatment. I just want to talk very briefly on mental health treatment before I get into modalities. And that's, we talked about ECT, we talked about, we didn't talk about insulin chemotherapy, but lobotomies was a big thing. That's how we treated mental health. If you've ever seen One Flew Over the Cuckoo's Nest, that was made big then, that was kind of the way they approached it. We had, of course, some medication management, antidepressants, Thorazine, benzos for anxiety. But as we moved into the 90s and present, we kind of moved away from that. The other thing that I think is important is around the 70s and 80s, they actually had it. It was a political thing. They moved away from large institutions. They called it deinstitutionalization, and they moved away from these big organizations that would treat mental health, and they recognized that they probably weren't the most effective. So they kind of moved away from those and really moved towards community-based kind of treatment opportunities. So I think that was a big move for mental health, very important um, for mental health treatment to move away from those big institutions and really thinking that the community could manage it. And of course, they start using more recognized treatment modalities, whether it's CBT, DBT. Even here with us at Promises, and we look at the landscape of mental health and SUD, we kind of, in my opinion, put it under one umbrella, which is what it should be. So when we talk about mental health, that's everything, including SUD. Sometimes we try to compartmentalize it and say, but the reality is people who are struggling with depression, anxiety, um, those diagnoses, the SUD population struggles with the same thing, right? So there's this idea of dual diagnosis. We know that comorbidity exists. We know it's more prevalent than we let on. They're both trying to work on their stress in different ways, correct? But it should be all under the umbrella of mental health. So when we look at treatment modalities for SUD and mental health, we should be looking at treatment modalities for both of them. That's one of the things I like about Promises is we approach that in the same manner. So we do a lot of DBT work. We're not 100% there, but we do a lot of work. We're 80% DBT, but we're teaching skills, and those skills can be developed for both SUD and mental health. So I really like that about Promises, that we kind of look at both of them in that framework. We may have some separate educational classes for those populations, but really kind of looking at treating that skill set to both populations. I think that's important. And then we move into some key trends that we're moving right now, and this is where we're at now. I talked a little bit about co-occurring disorders. What we're learning is that the majority of individuals, even with SUD, we treated an individual, and of course he came in for alcoholism, but he was severely depressed and had been depressed years. And at some point, his alcohol use just went up exponentially. But we know that he had both. He had the major depressive disorder, and he had, the SUD, alcohol disorder. So, co-occurring comorbidity is a lot more pronounced than I think even we let on. I think almost everybody entering it, it's hard. I don't think we have a single person we've treated at Promises Atlanta that didn't have more than one diagnosis. Just don't see it. We're big on measure based. We're big on evidence based. We're focusing on prevention. I go back to the trauma informed. I'm gonna spend a little bit of time on trauma informed at some point. Love trauma informed, and I think that's really important. Trauma's been around for a long time. It's not like a new thing, but all of a sudden, all these programs are very trauma informed, trauma care. It's a big push in our industry. When we're looking at people admitting into the program, they're debating between programs saying, are you going to work on my trauma? Are you trauma informed? Are your counselors trauma informed? And so that's a big idea and concept in our current treatment milieu. And then value-based, I want to spend a little bit of time just talking about value-based. I think insurance companies are going to go that route. We've been talking about for the last 2 or 3 years. I do think they're going to go there at some point, meaning they're going to give us value-based care is giving you an X amount of money to service a client, and whatever you want to spend in regards to that set amount of money, you can spend it on whatever you think it is, whether it's detox, residential, PHP, IOP, the myriad, but it's really kind of a value based. We want you to kind of garner and share with us the value that the client is going to get for the services that you do. So I do think that's going to continue to come. Insurance companies, when we get to landscape, is a big part of what we do or don't do, right? So. And then finally, before we jump into kind of highlighting 3 of the most impactful, I think, and currently widely used therapies, I just want to kind of talk a little bit about these other modalities. We're not going to spend a lot of time on these modalities. I think they're really interesting. The one thing interesting briefly as EMDR that stood out to me was it was done by this lady, Francine Shapiro, but that was in the early 80s. And she developed it by her observations on herself. So she's walking around, she's feeling this high stress level, her thoughts and feelings, and she's walking around. And as she's walking around, she is um, looking from side to side, and she noticed that her stress level went down. And then she did a little bit more work on that technique, and that's kind of the beginning phases of EMDR. But it's come a long way since then. Um, you know, EMDR is kind of the standard for the Veterans Administration, right? It's kind of considered the best practice for um, PTSD, and kind of the VA recognizes that. Um, so that's important. There's still some research about EMDR out there. There's still some research on whether the eye movement is that impactful. But again, there's still a lot of research supporting it. So, I'm gonna highlight EMDR. It's kind of the standard for treating trauma right now. And everybody's asking, do you have counselors? Along with that is, of course, the accelerated resolution therapy. That's a little bit shorter, so you can do that in a little bit shorter period of time. So, when we talk about trauma, we're talking about opening up this trauma, and EMDR is these long sessions, right? 16, 20 sessions, longer than that, in my opinion, for treating trauma. So, but we'll when we talk about art, that's what we're talking about. Kind of, they're treating it in a very short period of time. They have the resolution kind of in a couple sessions. They can do it, so that you're not opening this whole big trauma egg and kind of letting them out back to home, back to whatever. It's in a very accelerated period of time. So that's something uh, more recent. But I won't go into that. I'm going to focus on EMDR, those kind of things. I'm going to focus on CBT. CBT, which we kind of consider the gold standard. Why do we consider it the gold standard? CBT has the most research, right? There's the most research about CBT. There's really systematically, there's nothing else that they can find that is really superior. If you think about DBT, it came from CBT. So again, it's got the most research. Um, and it's just one of those things that most everybody knows it, uses it. It's used in all those different ones. I'm not saying it's the best. All I'm saying is that it's kind of recognized because of its research, its longevity, how long it's been around. And then I'm of course going to talk about DBT. So DBT, of course, is what we use 80% of our work here at Promises is DBT based, skills based. So I want to spend a little bit of time on that. So again, there's other modalities, and so for me, this is not about saying which one is you should use, which one is better. This is just kind of giving you the information. I think everybody has their different lens that they treat through. Um, but again, this is just to kind of let you know what's out there and what we're using currently in this industry. So we're going to compare these three, right? CBT, DBT, and EMDR. And we talked about CBT, the idea that behaviors are based in what that feeling is, that emotion at the time, and then we've got to go back before that. Right? We've got to go back to those thoughts, right? What are the thoughts? What are the messages you give to yourself that trigger that emotion, which trigger that behavior response? So that's basically kind of it. So if someone uh, calls us our name or says something to us, and our first emotion is anger, and we yell, or our first emotion is kind of um, um, guilt or shame, and we respond in that, going back to, well, what's the message you've been telling yourself that impacts and um, kind of made that emotion true? Is it I'm worthless, I'm no good, I'm not good at anything? What are those messages you tell yourself, and then how do we fix those messages, right? That CBT, and how we go from there, and what do we tell ourselves? DBT, I love DBT. Um, again, those four different things. I know they're all important. I think every single one of them, mindfulness, very important. emotional regulation, of course, interpersonal effectiveness. The one that I like that stands out to me that I think is, it's kind of my soapbox for DBT, and that's distress tolerance. And this idea that um, stress impacts every person, right? And how do we manage those moments of stress? And for us in teaching that distress tolerance is about that, is life on life terms, is that's what you're going to have. This imagined belief that you're going to go out there and you're not going to have any stressful moments, is not realistic. So for me, when we teach distress tolerance, is how can you increase that, right? How can you handle more stress, not less stress? Because if our goal is to go out there and have them encounter less stress when they go out in the world, again, we're not being realistic. But if we can teach them that, hey, stress and these events are part of life, what are the techniques to handle those so that your emotional regulation can be handled? I think that's an important. So I think it's important that we teach those skill sets on all four of these things. I think DBT is very important. It has its roots in that, right? It's what has its roots in that. And then EMDR, and I talked about that, right? It's recognized. There's about, I don't know, about 20,000 therapists that are a part of this EMDR kind of organization. There's 20,000. There's probably more who are trained in it, but 20,000 are part of this organization. It's an association. So it's very well, getting more research out there. It's being used more in this idea of desensitizing someone with their trauma, meaning getting them to change their emotional either content around that trauma, how they see it, their lens in seeing that trauma. So it's a big focus. Um, there are other kind of forms for working on EMDR. So I don't want to think that EMDR is it. There's neurofeedback. There's interpersonal mindfulness. There's other things. Um, the tough side on those things is there's less research on its efficacy. So there's not as much research on other forms like there is on EMDR. Um, However, the downside on EMDR is that um, um, the dropout rates are high. So they have a higher dropout rates. Other modalities to treat trauma have better rates to stick with it, right? And so the outcomes may look better, but that's because people stick with it versus EMDR. So just kind of want to make sure that we talk about that. Advantages of CBT, we talked about that, right? It's evidence-based. It's the most researched. It's adaptable. I loved it in group. I mean, I can teach it individually. I did it when I was doing some individual therapy. I loved couples therapy. That's probably my favorite. But I love doing groups, and so it's easy to do that. It requires someone being highly involved. You talk about groups, and you're teaching this. They have to be participating. They have to do it. They have to, whether it's practice it, learn about it. They have to be very involved. And it can be tough with teaching that with people who are in either trauma response modes that are dealing with that or are not emotionally regulated. So CBT has its limitations, right? So does CBT. So sorry, DBT. So we've talked about that. Again, what I like is it's the skills, right? It's the skills, and that's what we teach. We've had some great graduations here where they reflect on what that skills training has mean. They know they're going on to other programs, either they're going to PHP or IOP. They're going on to other programs. They're going to do other things. They're going back to life, whether it's work or the family. But we teach them some skills that they can take with them as they continue their work, right? For us in a residential setting, we know that we're just setting the table for future work, and we want to give them something tangible. The other thing that I think bodes well with DBT is you can do a lot of homework on that, right? It's not just in the classroom setting. Here for us, our therapists and nurses are well trained on using those skills. We're not training to be DBT counselors, but we are teaching our staff about the skills that the clients are learning, so that when they're out of group and doing their exercises or doing their homework or, you know, watching TV or doing, during dinner, the staff that are around them are very educated on those skills that they should be learning. I don't care whether the staff know it's called DBT. That's not important. What's important is they know the skills that were being taught. They know that they have to practice, and so our staff can point them back to that. Well, what are you doing with that emotions? I understand that you're feeling down, and I hate to hear that, but what are some things that you learned today? What grounding techniques? Are you grabbing something cold? Are you journaling? What are you doing? What are the skills that you're learning? So, and then of course it has some limitations. Again, trauma. It is a little bit more time sensitive. We spend a good 3 hours on those kind of things, so it is time sensitive. And then the pros and cons of EMDR, I've talked about those. The disadvantages, meaning the dropout rates. It requires someone who's really trained, but very effective for trauma. If you can get people to go through all those sessions, it can be very effective. The other thing that I think it struggles with is the comorbidity, right? I think that DBT and CBT handles that comorbidity of anxiety, trauma, depression, SUD, all wrapped up. And where do we start? And we can start with emotional regulation and mindfulness and stress tolerance and interpersonal skills, and we can start there versus jumping right into it. Our belief at Promises is that, for a residential and even a PHP, that's a lot of trauma to unpackage. And so we don't do a lot of processing, right? Our groups are not process groups, they're skills grouped. We're a trauma informed, skills based, family centered curriculum. We want to teach people to recognize, regulate, and respond, and that's our goal. So, we want people to work on their trauma. We're just saying that in our setting, that's not the best place for it, right? How do you unpack a lifetime of trauma, something that has significant impact on your life? A great example for me is dealing with my childhood trauma, and I sought out a therapist, and I thought after a year I was good. Like 1 year with a therapist nonstop, I thought I'm good. And then about 4 months after that, I had to go back for another year. So when we're talking about trauma, to work on something that has had a profound impact in your life, in relationships, whether they're current relations or past, and to believe we can do that in a very short period of time, again, I don't think that's the right expectation that we have for treating trauma in our industry. So, love trauma informed. Should we be treating? My opinion is that's a long-term thing and should be entered in with counselors. I hope we have some counselors and therapists on here. I highly advocate for individual therapy. I don't think that treatment is it to fix all that stuff. I think it's in conjunction, right? So we can definitely work together. These are what they treat with CBT. I think you can treat more stuff than that, right? Anxiety, depression. You can treat PTSD. You can teach those things. Some will be more effective than others. These are the things. Borderline. We talk the other things with borderlines and even bipolars is structure, 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 structure. Right. So we have a pretty structured day. We do the skills training, take a break. We do the application. We do a group where we're applying the skills that they learned, and then they're doing homework at night where they actually have sheets to work on those things. So these are really some good things to work for that. And then EMDR, we talked about the significance of EMDR. One of the other things that there's a newer version, and I didn't do a lot of research on this, so I'm open to hearing from anybody else. And it's a French term called mosaic. So in my research going through this, there's a French version which is like the EMDR. I don't think they use the eye movement as much. I think they use some of that, but it's mosaic. And they're getting some really, really good early research on that, is really showing some positive results in working on PTSD and trauma. It wouldn't surprise me if it jumps on the scene and we get people more trained in that. So I think that's an interesting piece and where we're headed. So those are kind of the highlights for those. Let me see where I'm at. Um, for me, it would be interesting to see in the comments, not in the chat, but in the Q&A, what are the modalities that you prefer, right? What are the modalities that you see? Why do you think they're important? And again, I've told you kind of my preference. I love CBT. I got rooted in that. I love the work we're doing with DBT. I think EMDR has its place. I do. I think that at some point, depending on the levels of trauma, I don't think everybody has to use EMDR. I get that the VA uses it. It's got the research behind it. Like my personal thing, my therapist did not use EMDR. I'm not sure I would have been open to it. Maybe I would have. So, but I'm going to tell you what I think um, in our second segment. I'll tell you what I think had the most impact, and that's where I stand. But put in the Q&A. What do you like? What do you use? I'll come back. We'll start the second part with that, and then we're going to jump into the landscape and wrap up this presentation. So let's take a 7 minute. Let's take a 7 minute break, and we'll be back at what? What is that? 10:56, something like that. All right. Thanks. Looked in the Q&A. I think I saw one question. Appreciate all the comments. So thank you very much for all the comments. Of course, I saw a lot of CBT, DBT, motivational interviewing. I saw a lot of person-centered therapy. We're going to come back to that again. So I like that one, motivational interviewing. We had a couple of questions about brain spotting, someone who's used it. I don't know enough about it, to be honest. I know that it was developed early 2000s. It hadn't been around super long. And from what I understand, there's not a lot of, it's for treating trauma. And it's based on kind of like the bottom up to the emotion. So if I'm not mistaken, it works on the physical stuff first so that you can release the emotions that go along with the trauma. So and inevitably you will deal with the trauma as far as the emotional content, but it starts with the physical. And they do that through looking at brain spotting, which is that central area of the brain, and seeing how the physical stress is impacting your emotional stress. If I understand, but I think there's needs to be more research. I think there's some studies that say it's better than EMDR. I don't think that there's enough out there to go either way. So that's a great question. So I appreciate that, and I appreciate all the comments in there. So as we move forward, I want to talk about our current industry and where we're at, and the impact of what's going on in our industry. And of course, you can see the prevalence not just of mental health, but of SUD and those who are struggling with it. I thought that the things that stood out to me in our current landscape as far as the prevalence goes is the number of SUD programs and the number of mental health facilities, and then the number of people that did not receive treatment in 2022, right? I thought that was, that's high. And we've all said that. I think if you've done a presentation or if you've been in a presentation, you've probably heard those stats, that we're not treating everybody. It's a small percentage that is seeking treatment, whether it's mental health or SUD, and that's what we're all focused on. And so there's the huge movement that's probably, I don't know, 15 years in the making, that we really started around maybe 2008, 2009, 2010. How do we get those people who are not seeking treatment? There's a percentage of people that just don't seek it whatsoever. And how do we do that? How do we catch that 55-year-old male who's been drinking silently behind closed doors. No one knows what, and then he's showing up to his doctor, and he's got the liver that's failing, and within 3 months, he's dead from liver failure, right? Where are those individuals and how do we get them? They never seek treatment. The family never seeks treatment for them. And everybody in the landscape is focused on how do we do that? And how do we find those people that aren't seeking treatment? So I think that's why that prevalence is so important. And then, of course, the barriers in our industry. Insurance is continues to be a barrier. I think it's always going to be a barrier. I think insurance companies are getting a lot more savvy on how they do things. They're learning just like we're learning. We're catching up to them. One of the things I've always said, one of the things I've always said in our industry is there's a lot of things that we should have been doing. We talked about measured based care, or outcome studies, right? In our industry, we should have always been doing that, right? We're playing catch up on those things, right? For us, it promises we do testing every week to see how an individual is doing. So if they're coming in with depression, not only do we put it on their treatment plan, but we want to measure where they're at week 1, where they're at week 2, where they're at week 3, and so forth. So we're measuring that stuff. We're catching up to that. We should have been doing that all along. So that's one of those things. I look at where we're at and where we're going. I'm glad that Promises does that. I wish all programs, and a lot of programs do that. So this is not me saying that programs aren't. They are, but we should have been doing that a long time ago. And that would help us as we kind of ask for, as we go to bat for our clients with insurance companies. If we had been doing those things all along, we would have been in a lot better space. Promises has done a great job of partnering with insurance companies and letting them know that we do this measure-based care. But again, where are we just getting to this? And it would have helped one of those barriers with insurance. So we're going to continue to see those struggles. Insurance companies are going to continue to fight and do those things. Qualified programs, that's more rural. When I talk about that, that's more kind of rural in nature is what I'm thinking about as far as limitations. Um, we have a lot of programs. If your state is a lot like ours, we're inundated. I think when some of the changes to the insurance companies and political landscape in Florida changed, Georgia, South Carolina, maybe not so much, but North Carolina, some of the other southern states, Tennessee, got bombarded with programs coming up from Florida. And again, so we talk about access, we have it, but in some parts, we're trying to get someone connected to a PHP who lives in rural Alabama and having a hard time, right? Because there's not a PHP program in the middle of nowhere, Alabama, right? So when we talk about a barrier, that's a huge barrier. This person may end up going to an IOP or an outpatient when they don't need that. They need a higher level of care. So, yeah, we may think, well, we've got, 17,000 programs. That's true. But where are they located? Right? They're not located. So, having to use telehealth, we have to use our technology to help those peoples. And then we still have fragmented care. Again, I love this idea of we have it promises, and other programs have this, is hitting everyone. So we're going from detox to residential to PHP to IOP, and we do that here. So we have our program, which is detox, residential, and we do PHP, and we want that continuum of care, but it's still fragmented. We still see people going to the hospital, whether it's the local hospital, whether it's a mental health institution, and then coming to us afterwards because they've stabilized on medications. And so we do still have this fragmented care system. And then we're moving into, we're moving into the digital age, digital front door. I talked a little bit about AI and where we're going with AI, and online platforms, and we're going to see more of that stuff to try to help. And I think in a lot of ways, it's very positive. When we talk about fragmented care, one of the reasons we use Encircle is because we want to make sure that we're following up with our clients once they leave. That we know we're a brief period of time in their journey, but we also want to follow up with them. One, what were we doing? Was it successful? But two, we've entered this relationship. We want to see where they're going, and if they need help, the ability for us to reach back out to them at some point, at some time, to kind of make sure that they're going. The last thing I'll say before moving on off of this page is I also think that we have done um, a challenging job ourselves in our own industry, and I'll tell you what I mean about that. The competition out there is extremely high, which is understandable. We have all these individuals who are not getting treatment, right? But in our industry, sometimes we're competing over the same people. So what I've seen grow when we talk about against medical advice or when we talk about against therapeutic advice, over the last 15 years, it has gotten so much worse. It was not this bad 15, 20 years ago. So it just wasn't. And we're seeing a number of those individuals leave. And I think we contribute to that. And I say we, I mean all of us in this industry, we contribute to that because we're so readily for them to skip from one program to the next, sometimes with no interruptions, sometimes with some interruptions. It's easier for them to do that stuff. They know that if this one doesn't fit what they want, they've got another one right down the road that they can go to and manage that. So we're caught up into this cycle just as much as they are into creating kind of that tough environment for us. And then we compete with ourselves on what we're going to offer rather than looking at clinically, what is appropriate. When we were looking at Promises Atlanta and being a part of a family of programs, we wanted to be very much so a part of what they're doing as far as clinical treatment. But there's also some things like we don't want to get caught up into this, hey, you can use your phone at any time you want. We want to treat it very therapeutically. We want to treat it clinically. We want to make decisions based on clinical care. So we involved our counselors versus just, blankets, you can use it when you need it. Is, hey, let's go through some clinical reasons. Let's make sure. So they're not going to use it in detox. They don't need it. There's no reason. They have access to a landline, right? So we have to rethink how we approach treatment as an industry. And if we're struggling through as an industry, how do we challenge ourselves on some of these AMAs and ATAs? I think we have to look at ourselves. Yes, we can look at the other people, um, but we need to do that. And then a lot of people will say that we're getting tougher clients. I don't think they are. I think the mental health is always evolving. Society evolves, diseases evolve. If you talk about cancer, right? You talk about cancer and how it evolves. Our treatment for treating cancer has gotten a lot better. We're seeing better successes, even though the disease itself has mutated and changed, and it's always going to do that. Medications and doctors and the medical field try to stay in front of that. And we should be thinking the same way, meaning let's stop blaming the clients and saying, well, they're getting worse. Their mental health issues are worse. They have more SI. They have more diagnoses. Now they're dual diagnosis. They have more comorbidity than they've ever had. And we start thinking about, all right, this is the landscape we have. This is who we're dealing with. How do we treat those individuals? So I'm all about forward thinking. I don't think that the individuals we serve have gotten more complicated. I think in some aspects we've always kind of rested on, well, this is how we do it, and this is what has worked before, not knowing that they're going to change, their disease, their illness is going to change. And so we've got to always continue to think about what's the next move. We got to move forward. What is the next area that we want to look at? So I think we need to continue to do that and drive that in our industry. Other influences, I talked about SI. Suicide rates are going up. We have reduced face-to-face interactions. I talked about telehealth. Social media impact, holy moly. again, we can't say enough about the impact of social media on depression, anxiety, especially our younger population. Um, the fact that they can look up and see how many likes they had on a certain post and they gauge their self-esteem for that. Um, my wife has always said that the phones probably will be the death of our society. It could be. Um, I think there's, the technology and information age. I appreciate the ability for us to find information rather quickly. What I don't find very healthy or appropriate is how people change that information to fit whatever they want it to fit. And that's the industry we're in. And, some of us who have been through a lot of different situations, and I say that in a nice way of saying us old people like me, we've been through a lot of stuff and we can manage those emotions. But can you imagine young people that are going through that, right? I don't want to get into anything political, but when we look at social media in 91, 92, when we went over to um, Kuwait, my era, we thought that was it. We thought World War III. It didn't happen, but that's what we thought. We sat up all night. We watched the videos. We did all that stuff. So, when this happened, this most recent thing with Iran, my son, who's 25, he's calling me up. Is this World War III? And he's thinking this is it. So, those are the social media kind of impacts that we have. We have so much information at our fingertips, not just the social media and the impact on mental health, but how we see life and move forward, and how we see current events in the U.S. versus political events in other countries. Right? Pandemic had a huge impact on treatment and what is accepted telehealth. Um, the changing family structure. We go back to that idea of the nuclear family of when it started, right? We're seeing the change in the family structure and landscape, right? We've got a lot of people not having children. We have identification. We're looking at gender. We're looking at race. We're looking at all kinds of changes in the family structure. What we thought was looked like a healthy family, and maybe the nuclear family is no longer healthy. And being in a part of that and moving forward, and what does the family structure look like? And how do we accept all different kinds of family setups, whether it's extended family, whether it's a shorter family, um, whether it's families living multi-generational together, and then also not neglecting nuclear families and saying that's wrong. There's still a pocket for that, but we're expanding what family means and what family looks at. And sometimes it's not just biological genetic components, it's family of friends and people, communal friends living together. So there's a lot of expectations and challenges in the family that we have to look at as well. Those are some of the influences us. And then we have to look at theoretical considerations, right? How do we see the world? What is our lens as a clinician? You put in there in your chat your modality. Is that how you see the world? Do I see the world constantly from CBT? Am I always thinking everybody their behavior as far as goes back, and how do I see that when I'm treating clients? We had a great example. I'll talk about that later. But we had a great example where looking at a client, and we're talking about him in our treatment team, and it's like, hey, are you viewing this kind of issue through a DBT lens or skill sets? Can we go back and look at CBT and how that might impact this person? So what is our lens? There's increased education around mental health. Nowadays, there's this big push. I push it in our staff training, authenticity. People want someone who's authentic and real. They don't want that fake person. So, we're having to be that authentic counselor. You can't be a robot, right? We're learning and understanding more about the interconnectedness and interdependence, right? Interdependence, we kind of stay away from the use of codependency. We're all interdependent, right? Um, we um, we're reliant and we support, but there's this idea of balanced, and it's mutual, right? It's mutually respective, and Um, how are we not just connected, but how are we interdependent on each other so that it's mutually beneficial us both as in a relationship, right? So theoretical considerations, and then of course mind, body, um, spirit. So what does this mean for me in my practice? That's kind of where we get to. So when we talked about the history um, of psychotherapy, we talked about the landscape and how we got to where we are. The current challenges, I talked about the barriers and how much are in practice in there. But how does this impact me in my practice? How does it impact me in my treatment of individuals? Again, I want to talk about that. There's several things that I've outlined. So I do want to talk about those, but I want to talk a little bit about the impact when you have clients right in front of you. Like, what does all that information mean to me as I have a client sitting right in front of me? So I'm going to segue into this, and I hope we can see this clip. I embedded it into my presentation, so we will see if it works. So, sidebar, I love movies. I mean, I just love movies. I like all kinds. I do have a favorite genre. Yes, I like horror movies. I like revenge movies. I like foreign films, but I like all kinds of good movies. So I love movies. They play a big impact in my life, not just in downtime as far as stress relievers, um, but even in my family, TV shows and movies. We have a lot of we have a lot of back and forth that we've picked up from movies, um, and we just use that in our everyday language. So I found a movie clip, and if you like therapy movies, there's some good ones out there. You have to remember most of them are fiction, even if they're based on nonfiction, they turn into it. Like Ordinary People, One Flew Over the Cuckoo's Nest, Silver Linings Playbook, A Beautiful Mind, all great stuff, all great films, and I liked them all. I do have a particular favorite just because it was my coming of age. I was in my master's program at that time when it came out, which ages me a little bit. Most of y'all have probably seen it. So I play it. I understand that it's not um, how counseling goes, but I think it would be interesting. So I'm going to play it. I hope it plays. I hope the sound does, and we'll talk about it afterwards. But I'm not recommending that this is how we should treat our clients. That's not my recommendation. Although I like this scene. I like everything about this movie. Good Will Hunting, if you haven't seen it, it's a great movie. Get a chance. I'm going to play this clip and then we'll talk about it afterwards and why I played it, why I think it's important. All right. So let's see if this works.
Bill, I'm not sure we're gonna get the sound.
Yeah.
Maybe try that left in the volume on the actual video there.
By the volume where?
All right, there next to that play button.
Oh,
Yeah. Nope, that's up. Actually, why don't you try putting that? Ooh, if we try full screen, let's see what happens. Maybe it'll
this one?
open. Nope, can't do that.
No. This sound is not there.
No, what about the YouTube button? What happens if you click that?
Where?
I think we have to allow for the sound in a video to play, and that may be a separate setting that we didn't do ahead of this. I
So
didn't
it's
know.
still no sound.
No sound. But I can absolutely link the video if you want to just save that link and send it to me
Yeah,
after we can add it to the resources.
no worries. Sounds good. Let's see. I'll go back to it. So no sound. So sorry about that. That's one of the things that happens, right? So so I'll just talk about it because I can share it with them.
Yeah, just act it out for us.
I'm not gonna. They definitely don't want me to act it out. That would be even worse than saying. But I'll talk about why I do this. And again, if you've seen the movie, um, really good movie. I highly recommend it. I'm not suggesting or entertaining that this is how therapy should work. However, in this scene, so I'll kind of couch it because I kind of want to make sure we understand why I'm bringing this into play. So Will Hunting, his name's Will. He has been mandated by court to do therapy because he's gotten into trouble again. He's been in trouble his whole life. And he's got some serious, significant trauma. And when I say some significant, it is a lot of physical abuse. He was a foster kid in and out of foster homes, a lot of physical abuse and just intense, right? And so he's mandated treatment. And so he'd go to all these therapists and they would try. So one therapist tried hypnosis and it didn't work, and another one would try to visit his childhood. And Will could see through all these things. He's a highly intelligent man. You don't know this. He's just super smart. He can read a book and just know the book. So never been to college, probably didn't finish high school, but he can just read books and just knows it. He knows all the information, smart as can be. So they finally get him in front of Robin Williams. And in their first episode, their first meeting, Robin's just trying to get to know them, right? Just trying to get to know them. Hey, let's talk. Where are you from? All those kind of things. And this guy, Will, just wants to go cut right through that, looks around his room, and just methodically picks on things until he finds something in that room that hits a raw nerve on Robin Williams, right? So he just did it. I mean, that's how smart he was. He was like, I'm going to find something that's wrong with this guy. I'm going to pinpoint it and I'm going to figure it out. And he does. He finds this painting and he talks about this painting that Robin Williams did in there. And he talks about, hey, it's about your wife and your wife must have left you and all that. And so he just goes at him and dissects him, right? And Will leaves thinking he's won. Like, this guy, Counselor Robin Williams, is never going to want me back. He's won. And he's thinking, that's it. There goes another counselor. I'll find another one and find it another way. And Robin Williams just kind of says, yeah, I'll see you next week. So he takes them out. This is their second follow-up, and they go out to the park. And he kind of basically says, um, I thought about what you said, and it occurred to me that you're just a hurt, scared little boy, and I slept through it and haven't thought about it since. And so that basically what he says is he says to him in a very direct way that I appreciate you being smart, but you haven't experienced life at all. Like, everything you've done is through a book. You haven't been anywhere. You haven't gone anywhere. You don't know anything other than what you've read. And you're going to tell me everything you've read. And he goes, basically, I don't give a shit about what you've read. I don't give a shit about anything that you've learned, right? He said, basically, I want to know about you. And if you want to tell me about you, and if you want to be in a relationship with me, and if you want to talk about you, I'm here. I'm all in. We're in this. But if you're going to regurgitate books and you're going to share with me what you've learned, then I'm out. I don't want any of it. So that's basically that clip. And then your move, chief, is basically he says that to him, your move, and he leaves. And he sits there. He lets Will sit there and ponder it. So that's basically that clip. I know I took a little bit of time to explain it, but I just wanted to make sure I was thorough. You've probably already seen it, which is cool, but I just wanted to make sure. And I'm sorry I didn't play. It's such a good scene, and I'm definitely glad I didn't act it out. So why? Why did I show that clip? I have probably preached this time and time again, and I share it. And you can ask my therapist that I work with now. You can ask the therapist that I work with at all my other facilities. I've held the role as clinical director several times. I'm better as an executive director. That's my strength. That's where I do really, really well. I'm good as a clinical director. There's a lot of nuances that quite escape me. I'm glad I have people around me who are better equipped than I am at that stuff and really help me out. Left on my own, I would stumble and fall flat on my face all the time. But the thing that I've always said most is the most important part of therapy is the relationship. Hands down, bar none. That's it, right? So when we're building that therapeutic relationship, what are the parts of that that get us in that relationship? If you're entering into that client session therapy and you're thinking about, all right, when do I introduce DBT? When do I introduce CBT? When we're doing our groups here at Promises, we may tell them that this is what it's based on, but we don't spend a lot of time. We teach them in regards to their current issues and what they're dealing with. So we actually draw on their issues that they're doing. So the challenge in relationship building is you've got to do a little bit of self-disclosure, not the unhealthy kind, not when you're telling them I was sexually abused at the age of 4. We're not talking about the unhealthy thing, but them knowing that you have kids, that you're divorced, that you're not in a relationship, right? I lost my parents. You know, there's got to be a part. There's got to be the human part. You've got to be able to challenge them, like we showed on that clip. You know, I mean, he challenged him, directly. Am I saying you have to be confrontational? Absolutely not. Was he a little confrontational? Absolutely. It was a movie. It had to be dramatic. I would never say, those. I'm not advocating for cussing in your sessions. I am advocating for being authentic and real, right? And if it comes up, it comes up. Um, but you have to challenge a little bit. You have to challenge behavior, right? So I come back to that moment, when us as therapists were talking in treatment team about this client, and what skill sets are we using? She's wanting to process trauma that's really not healthy at the time, and then we talked about, what we do as far as the behavior and how do we challenge her thinking about behavior and where does that come from her messages that she tells herself to, or we're using a little bit of CBT. And I just asked, I said, what do you want to tell her? Like, if you were talking to me and I'm throwing out my trauma and not a time that I should be talking because it's not helping me, what would you tell me if I was doing that? She goes, I would tell you to stop. Like, it's not the time, that it's not helping you at all. Please don't do it. We'll get into it at some point, but now is not it because you're not able to handle it, right? There's a very challenging kind of message. And I said, that's what you should say to her, right? That's what you should say. Just challenge that behavior versus getting into how do we teach that? Maybe there's nothing in that moment. We have to be relational. We have to be analytical. And I don't mean just of the client, right? We have to be analytical of the environment with ourselves and where are we at in meeting that person, and are we meeting them where they're at, right? Are we meeting them in the space that they're able to communicate their needs and wants? So these are the important aspects that we're talking about in being in a relationship, right? This again, I think, is why it matters, right? There's evidence-based consensus, right? The quality of the relationship is stronger than anything else. That is the key. So when I talked about my own stuff and I did a year and then I had to go back in a year, I don't know that she had a modality. She probably did. She was trained, she was licensed, she had tons of experience, she was doing it for a long time. But the things that I came back to that impacted me, I think, were the person-centered therapy approach. And she may not even have been doing it intentionally, but that's what I remember about that. Right? I remember the unconditional positive regard and everything I would say. When I would say, I think I may have killed my mother. When I said, I think that my wife doesn't love me because of these behaviors. There was no judgment, right? There's this unconditional, positive, right? Love in that. There's empathy. There was genuineness, right? So when we talk about that therapeutic relationship and we go back to Carl Rogers and we go back to person-centered, I think someone put that in their chat. Someone said, there was a couple people, there's more than one. A lot of people said person-centered therapy, right? And I'm not saying that's what we should be using. So again, I'm not advocating against any other modality because I love them and I use them. But when we have that person right in front of us and we're dealing with that person right in front of us. We can have all those lenses and perspectives, and we can know everything we want to in our changing landscape. Um, but what is going to impact that person? We had some great graduations here at Promises, and I told our admission specialist who sits in front, and I get to talk to her a lot. She's awesome. She's so good. She helps keep me grounded. And I just said, I think the reason she did well was because we loved her. Like we just loved on her. She was a tough case and she did really well. And so she had a lot of trauma. We did our DBT. We didn't discuss the trauma. And after graduation and going back and doing some work, she was able to go to her aunt's graveside, who she loved. She hadn't been there for years because it just brought up too many memories, and had a great picture. She was smiling and she was able to do these things. And again, I think the number one impact was our nurses loved on her, our therapists loved on her, and that's just how she kind of got that treatment through us. Yes, we taught her skills, and she did them. You know, she would use them on a regular basis. But the most meaningful impact was that relationship, right? Across any other kind of, um, you know, techniques or modalities we use. Um, that's kind of got to be, and we got to think about their experience, right? Their experience um, with us, and what are they getting out of it, right? How do you get there, right? How do you get there? Cultural competence, yeah, you got to know who you're dealing with, whether it's being a therapist individually or in a treatment setting. You got to know the culture you're dealing with. I love the patient-centered approach. You have to be flexible and adaptable. You know, that's what I was telling about our industry is sometimes we get so focused on what is we get caught in ourselves. I was doing a tour and someone said, are all your staff um, trained on DBT? And I'm like, yeah, they're trained on our curriculum, but our curriculum is broader than just DBT. But we're so focused that even people who come to visit are always asking those kind of things. Are you trauma informed? Are you? And we're getting so hung up, in my opinion, hung up on that stuff. I'm not saying that's not important. I love trauma informed care. We should all understand the impact of trauma we have on treatment. Everybody in this, if you're licensed and you're educated and you need to either be trained or taking a class or continuing eds about that stuff or seeking out your supervisors to get trained on that stuff. But we have to move past that. That's not the only thing we should be looking at, especially from us. If we're saying that trauma is treated over a year's time or a year and a half or 2 years' time, what are we doing if that's, if we're trauma informed, but we're not going to trust their trauma, what are we doing? What's our modality? That being that trauma informed trained really didn't help much other than we're aware of it, but we're going to need to focus on something else. So we've got to be able to adapt and be flexible. And then we have to be humble, right? Um, we have to recognize our limitations. I say this all the time. You can ask any of my staff, my therapist, that I have so many limitations. I have more limitations that I'm good at, right? Um, I I I, I want to be better at that stuff. I'm just not, right? And I try and I grow and I listen. Um, and I try to get those things. And then when it comes to clients, we have to recognize that clients are the experts on their own lives. And I'll say this when I'm meeting with someone individual. If I'm doing the group, I always say I am not the only thing I'm an expert on is um, I can approach you in a very genuine, humble way. I'm pretty good at that, right? I'm pretty good at that. But as far as your circumstances, I don't know your circumstance. I don't know your life. You know your life. I can tell you my thoughts and I can tell you my opinion and I can give you a skill set. But you're the expert on what's going on in your life. So we have to be able to recognize that and stop thinking we know better or best because sometimes we don't, right? Um, and so why did I pick that title, right? And I picked that title um, because I think as an industry we've got to continue to kind of challenge ourselves to take that humble approach. I think rather than thinking we know best, and we deal with it on a lot of different levels. Policy, we deal with it with compliance. We deal with it when we're talking about evidence-based care, right? And we think we know what makes those. We think we know what is compliant, non-compliant. We think we know best about policies. The thing I love about policies is you can change policies. So if it doesn't match, you can change that policy. But as an industry, I do think that we've got to um, move forward and really kind of take a very humble approach to not just our limitations, being open to be flexible and learn, to avoid those power imbalances. We've got to understand culture. We've got to be able to self-reflect, right, on how our work is impacting the clients and whether that's appropriate. You know, sometimes individuals, and I just see this as a self-reflection, and I've had to learn sometimes, the individual wants to go to the executive director because they don't like what's going on. And what I've learned through experience and in tough ways is that's not appropriate because you've bypassed that therapeutic relationship. And then meeting with them, I have just trampled on that. And it never goes well. It's never gone well. So I stopped doing it just because I don't know best. I don't know them. I should stop meeting with them because I was arrogant enough to think I could help and I couldn't, and really push it back to that relationship. And I had to learn the hard way. And I continue to learn. I'm still not perfect at the things I do and still challenged by my staff. But my goal is always to take a humble approach, always to look for ways that I can learn, always look for things that I can do differently. And I think that's what's going to move us and drive us as an industry. I think if we continue to do that, I think we do have to have this kind of person-centered approach when we're talking about that immediate client. I think we can use our modalities to the best of our ability, but I do think we need to kind of come back to that genuine, authentic, humble approach, knowing they are the experts on their lives and how can we be of service to them. And then I'll kind of end on that. That was kind of the basic of my premise, is getting back to that person-centered therapy that y'all put in your Q&A there. I really think that's where we should go as an industry. I was having a conversation with an individual, and as an industry, we have insurances and everybody, there's pockets of it. There's pockets of programs that are very invested in staying focused on quality clinical care. And I think how we change this landscape and how we make our impact today is by doing exactly that. Is focus, instead of focusing on what's going to get us the insurance payment, what's going to get us more revenue so we can, yes, we need to put our money back into our programs and into our practices. But I think if we can shift gears in the next 5 to 10 years and really focus in on what is going to impact clients the most and get them the most benefit, and that's in that relationship, and humbly looking at ourselves and learning and challenging and growing and getting better, and not get caught up into the competition of one program's better than another program, and focused on how can we get better, how do we focus on clinical care. I think that's going to be the change. That's going to be the change in the industry that we want. So with that, I will kind of open it up for any comments, questions in the Q&A. I can look at those and see if there's anything, but that's kind of where the presentation ends. Let me kind of share this next slide just so we know what's coming up next month. I know Callie will share that next month. We do have Pathways to Healing. Trish, she's incredible. She's really good, really good. Knowing that I was like she did last month, and then she's going to go this one, it's a little daunting because she's just an incredible speaker and does some great things. So I think it'll be worthwhile for next month. And then again, if you're in the local area, don't forget we have our open house on July 25th. It's a Friday. Would love to see y'all there. So, all right. Let's see. Says starting LCSW coming Monday. Yay. Open gyms for me to be open and seek out. A lot of good programs out there. Keep your eyes and ears open. So yeah, there's a lot of great programs out there. Yep, clients are resistant to opening up. Those that it can be the hardest thing. So finding that opening, right, to get in front of people. So it is hard. And there are some they're tough to find, but there are some programs out there you just have to find for people who are uninsured. They have opened up insurances for a lot more people, but they're out there. I will try to track some down and see. And yes, there are tons of virtual programs. One of my favorites is is it centered therapy for virtual? But they're getting more and more. But centered therapy is a good one. It's in the Atlanta area, but they can take out of state people. So there's a lot of good stuff out there. So good question on imposter syndrome. I'm not very familiar with that, so that might be for someone else to look at. Let's see. All right. Anything else I missed, Callie? Callie's on hold. Like I said, I really appreciate it. Appreciate everybody attending. Kind of was like riding a bike, but a little bit more challenging than riding a bike. Just FYI.
Thanks, Bill. Were you able to get through any of these questions? Sorry, my dog
Yeah.
was demanding to go outside. I missed the last couple
No
minutes.
way. I did. I talked about some. I don't know if anybody that was extra. There's a couple that, of course, they were great comments and great ones. Do I tear up? I tear up all the time. And yes, it's appropriate, very appropriate. So I think that's part of being that genuine. I mentioned you boohoo about your own stuff, but no, but connecting with someone who's sharing something tough, it makes us human. One of the things I've shared with therapists too is whenever you get to the point where it doesn't touch you or doesn't impact you, leave. Like you shouldn't be in therapy. It should always impact us. We should have some emotional content. Now we can't take that emotion away from them. We have to give it back to them. If you believe in that container method model, you take it for a very short period of time. You give them a sense of relief, but you got to give it back to them. They have to carry that emotion. That's for them to be with. But man, yeah, absolutely. I think you should be real and authentic in the moment. So that was a good one. Great question.
And the only other thing that I will add, I'm sure you just spoke to this, but for next month, if
Yep.
anyone here has not heard Trish Caldwell speak, she's amazing. She's runs
Yes.
the show, and she could talk about what she ate for breakfast, and it would sound like the most important thing you've heard ever. So,
Very true.
if anyone has
Very
any
true.
other questions, they could drop them in, or if not, again, we'll have the recording of today, the key slides and resources that Bill has mentioned, including that video. We'll get everything uploaded next week into the attendee dashboard. Reminder for the evals, complete that sometime next week. You should see that in your attendee dashboard today. And that certificate will come to you automatically. So if you have any other questions, you can find us at pbhu@promises.com, and we'll see you next month. Thanks, Bill.
Thank you.
Thanks, y'all.